Hi, I'm Dr. Tracy Marks, and I make mental health videos every Wednesday. Today, I'm talking about obsessive-compulsive disorder and how we treat it. Today's topic is based on 2 viewer questions. WTT says, "My biggest compulsion was rumination. I thought I was a pedophile, homosexual, I'm straight. I always thought something bad was going to happen. I wish I knew more about this disorder earlier. It's taken me 8 months just to try meds due to my fear of doctors and medication. Please do a video on OCD." Then Enam says, "I was diagnosed recently with pure O OCD, and I have been dealing with this distressing problem since last 9 years. Can you please do a video on pure O OCD since it's a widely misunderstood illness? A lot of people are aware of that, and it's not like normal OCD. What causes it? How can we treat it? And what are the symptoms, etc." Thank you, WTT and Enam, for these questions. Obsessive-compulsive disorder is an anxiety disorder whereby you have either obsessions or compulsions or both. Most people have both, but you can have one or the other. This addresses Enam's question about pure OCD. Pure O is not a separate diagnosis, it's a descriptive term that people have come to use. Even though more people have both obsessions and compulsions, I wouldn't go so far as to say that it's normal OCD and that if you have only obsessions, that you have a misunderstood illness. People who treat OCD know that you can have either or, but I think people believe that the compulsions are the normal OCD because that part is observable. You can see someone performing a compulsion, but you can't tell what's going on in someone's head if they don't tell you. And for some people, the obsessions can be so disturbing that they don't tell anyone. You may not even tell the doctor that you see what obsessions that you're having. You may go see the doctor for anxiety or depression and still not admit that you're having these obsessional thoughts behind it. The obsessional thought may be that if you speak to someone about something out loud, that your family's going to be harmed. So of course you don't want to say anything. Oftentimes, people with OCD will have dysfunctional beliefs. You may put too much importance on a belief, as if having the belief makes it a fact. Like WTT said, if you have a thought about some taboo sexual act, in your head, it can be as if you did it yourself. People with OCD can have poor insight into how realistic their thoughts really are. An example of this would be to actually believe that if you do not turn your faucet on and off 20 times, the water will leak out and flood your home. If you ask a person, how can that really happen? They can't give you an answer. They may say, I don't know, I just believe it and I can't make myself not think that. In this scenario, if you can't be convinced that the outcome is not possible, your belief would be considered a delusional belief. But this is one of the few instances where you would not be considered to have a psychotic illness. In this case, your diagnosis would be obsessive-compulsive disorder with delusional beliefs. The term delusional beliefs would be considered a coarse specifier. There are some common obsessional themes with OCD. Contamination obsessions, with or without cleaning compulsions. Symmetry obsessions. And this may come along with repeating, ordering, and counting compulsions. Forbidden taboo thoughts, and this is where you can get aggressive, sexual, or religious obsessions.
Nice.
And then there's the harm obsessions, and this can be fears of harm to yourself or someone else. Sometimes a woman can have a baby and have the thought pop into her head that she may harm her baby. And a really scary thing about OCD is that it's not always thoughts. Sometimes the obsessions are images. So a new mom can have a flash of seeing herself hurt her baby and be completely freaked out thinking, why am I thinking this? Something must be seriously wrong with me. Some people respond to the harm obsessions by checking or hoarding. Hoarding is its own disorder, but it falls under the category of obsessive compulsive and related disorders because it is similar. But it's a separate disorder when it's not due to OCD. I've talked about compulsions, but what are they? Compulsions are repetitive behaviors that you're drawn to do because of an obsession or a belief or set of rules that you feel like you have to follow. An example of this would be needing to open and close your car door 5 times before you can get in, or walking into a room that has tiles on the floor and needing to count all of the tiles before you can feel comfortable in the room. The compulsions are hard to resist performing, and they typically give you a lot of anxiety if you don't follow all the steps. And for the diagnosis of OCD, the compulsions or obsessions need to be time-consuming, taking more than an hour of your day. So if you're someone who tends to check your locked door twice before you leave the house every morning, that is compulsive, but it's not a disorder. There's a certain amount of normal compulsivity and obsessionality that anyone can have. With the compulsions, you can recognize that it's something unreasonable, but you have to do it to relieve your anxiety. So let's say you need to check to make sure you've turned off the oven before you can leave your home. You go back in the house and you check to see if it's turned off, and then you go back to your car. But then you have the urge to check one more time. So you say to yourself, you know it's off, but you just can't feel satisfied until you check that one more time. If you try and force yourself not to check, you can leave with a lot of distress and discomfort, and maybe at even some point in the day, you may even question whether you really turned it off. It's like your memory of checking it changes, and now you're not sure sitting at work or school, and you've got a lot of distress about it. Obsessions, on the other hand, can be something that become hard to talk yourself down from. For example, let's say you fear getting HIV infection. Intellectually, you know that you get it from human fluid exchange. You can't get it from touching a doorknob or shaking someone's hand if you don't both have open sores. But you go to a party where the room is thick with people and someone sneezes behind you, and you can feel the drops hitting your shirt, and you can even imagine the nasal drops going through your shirt and into a hair follicle on your back. And now you have HIV. You come to see me, and I tell you that's not a reasonable way to contract HIV. You leave my office feeling somewhat reassured, but you still may go get tested anyway because you just don't believe what I said. The gold standard therapy for treatment for OCD is called cognitive behavior therapy with exposure and response prevention. Essentially, you're exposed to situations that trigger your fears or urges to do the rituals, and then you abstain from performing the ritual or doing your usual coping mechanism. This treatment can also help you if you only have the obsessions, or what people would call the pure OCD, because you probably have developed some avoiding behaviors. And these avoiding behaviors could be the focus of your treatment. So instead of having an obsession and performing a compulsion, you have things that you don't do anymore because you know that they'll trigger your thoughts. And you may be losing out on things because of the fact that you're now avoiding certain activities. Here's how the therapy goes. You would create a list of feared situations, ranking them from least distressing to most distressing. Then you would expose yourself to the situations. And it can be an actual exposure, which we call in vivo, or it can be imagined. An imagined exposure would involve creating a scene in your mind of the triggering situation. The therapist would help you create the exposure situations based on the list of feared situations that you create. Here's an example. Suppose you fear being contaminated by touching things that disgust you. Here's what your list of exposure situations might look like going from low to high. Touching a doorknob. Touching a gas station pump with your full hand, including the palm of your hand. Running your entire hand along the top of a public toilet seat and then being unable to wash your hands for 10 minutes. Touching someone's sweaty back and then touching your chest with that same hand. Putting your finger inside someone's ear canal and then continuing to use your hand in a normal way that incorporates that ear finger. I promise I'm not making this up. Now these things might seem like extreme circumstances that you probably wouldn't want to do even if you didn't have OCD. But when you don't have OCD, you're not consumed with thinking about things like this. It may gross you out if someone asked you to do it, but they're not thoughts that you create in your head. But these are the kinds of thoughts that people with OCD can spend their time thinking and worrying about. The exposure response prevention immerses you into more extreme forms of your fear situation to desensitize you from the things that you actually fear. The goal of the treatment is to not only be able to stop the behavior, but to see that you can master your anxiety and it doesn't have to consume you. You also learn that the anxiety you feel doesn't have to last forever and it actually goes away. When you have the urge to perform a ritual at the time, you think that that's the only way that you're going to feel better. But the treatment helps you break past that belief by giving you the experience of having your anxiety actually go away without doing the ritual. And for those who have harm obsessions, the exposure therapy can teach you that the consequences you fear don't actually happen. Sometimes you're too anxious to benefit from the therapy, or you don't have access to a therapist who does this kind of CBT. In this case, the treatment for OCD would be medication, and we use the serotonin-enhancing antidepressants. The medications FDA approved for OCD are fluoxetine, fluvoxamine, paroxetine, sertraline, and clomipramine. Clomipramine is a tricyclic antidepressant. It's one of the older medications, and there's some data that suggests that it's a better medication for OCD than the selective serotonin reuptake inhibitors. However, it does come with a lot more side effects, including sedation, blurred vision, weight gain, and a host of other things. If your obsessions rise to the delusional level, you may need to take an antipsychotic medication that would be added to your antidepressant. Aripiprazole and risperidone are common medications that we would use for this purpose. There are also neuromodulation treatments such as deep brain stimulation, transcranial magnetic stimulation, and electroconvulsive therapy, or ECT. ECT would be used for OCD that comes along with depression, and usually not just for OCD alone, but we do use TMS for OCD alone. You can check out my video I have on neuromodulation devices. See you next time.